Good evening, everyone, and thank you for joining our briefing on how to respond to the government English consultation on DIY abortions. My name's Isabel. I'm one of the directors at March for Life UK. For those of you who haven't heard of us before, amongst other things, we organise pro-life public witness events to create awareness of the hurt and the damage that abortion causes. One of our key events this year will be on Saturday, June the 5th. So if you can keep that free in your diaries. Obviously, we'll be adapting to whatever the government guidelines permit us to do on that date, but we will be regardless having some kind of an event on Saturday, the 5th of June. And I think adaptation is the key word at the moment. We can't afford to be idle and we can't afford to be silent. And what we're doing this evening is a really positive example of this. We're finding a way to be proactive about our pro-life beliefs, even in spite of the lockdown. One of the things that we've been doing recently at March for Life is recording some testimonies of women who've been through DIY abortion experiences. Now, these are really harrowing to hear, and I'm sure they were harrowing for the women to relate. But I just want to encourage anyone this evening, if you've been through a DIY abortion, or if you know anyone who's been through a DIY abortion, firstly, to make sure that you or they get some healing, I'd really encourage you to contact Rachel's Vineyard, which provide help in healing and finding peace for women and men who've been through an abortion experience. But also, I'd like to say that if you feel that you might be in a position to share your story, whether that's in a written form or through a video, so it could be done anonymously if you want, then please come forward, get in contact. I know this is a really difficult thing to do and it's a very sensitive subject, but we need to get these stories out in the public domain. And it can be a really beautiful way of honouring the life of your child. Now, this briefing today is being brought to you by a coalition of organisations working together in response to the government consultation, the outcome of which could make a dangerous policy permanent. So I'm going to be handing over to you. I'm handing over to Alethea Williams, who works for the SPUC, and Kevin Duffy, who's an independent health consultant. Now, they're going to go through how to respond to the questions on the consultation. There will be an opportunity at the end for Q&A. If there's anything that's not clear during this briefing, please just drop a message in the chat box and we'll answer as many of the questions as we can, either at the end or during the session. Thanks again.
Thank you, Isabel. Thanks so much for your introduction. And thank you everyone for joining us this evening. So I'm Alethea Williams and I work in the campaigns team of the Society for the Protection of Unborn Children. And I've spent a lot of the last year thinking about DIY abortions and writing briefings on it. So to begin, I just want to reiterate why it's so important that we all fill in this consultation. And obviously we're a coalition of pro-life groups. We oppose abortion, we want to end abortion. So it's a fair question as why we're worried about exactly where these abortions are taking place. And it's true that, you know, an abortion carried out in a clinic is morally wrong at home. But for the purpose of this consultation, we're asking pro-life people to put the case to the government of the dangers to women from home abortions. And it's also the case that home abortions are part of the abortion lobby's agenda to make abortion completely normalised so that you can get over the counter with no restrictions. So we have a really important opportunity here to oppose this agenda. And so we have this chance to respond. So we need to do so. It's also really important that we get a large response to this. These consultations are a numbers game, essentially. So what we want to do today is make it as easy as possible for you to fill in this consultation. And we'll just begin by having a quick look at what the consultation looks like. It's on the government website. It's actually quite easy to fill in. So we're just getting it up on the screen now. So you go on the Department of Health and Social Care's website. They ask you some preliminary questions, you know, the kind of normal name, address. You actually don't have to give those details if you don't want to. And once you're through that, there are 10 questions. Some of them are tick box responses, and then there'll be boxes for free text comments. So you choose the option that you want, and then there's a space for comments. So what we're going to do today is we're going to go through each of these questions in turn, and we're going to give you some suggestions of points you might want to make while answering these questions. So don't feel you have to put everything we say, and obviously put it into your own words. Kevin and I are coming at it from slightly different perspectives, so you may find that some lines of argument appeal to you more than others. So take what you find useful, obviously put anything you think in as well. Yeah, so just before we get started, just a few little facts to bear in mind. So when we're talking about the limits here, many of you will know that the normal abortion limit in this country is 24 weeks, but for this pills by post, the limit is 10 weeks, so which is based on medical practice and is also a legal limit. So if we're talking about 10 weeks, that's why. Okay, so to jump into the first question, do you consider that the temporary measure has had an impact on the provision of abortion services for women and girls accessing these services with particular regard to safety? So obviously this is a very important question. We're very worried about the safety implications of this measure. So we suggest that you tick, yes, it has had a negative impact. And some points that you might want to put here. Again, some of these points you might want to put in the answers to other questions as well, because safety is a very big concern. So first point might be carrying out a DIY abortion at home is a painful and traumatic experience for women who are often alone. We're also worried that vulnerable women can be forced into taking abortion pills. You've probably heard that there was a spike in domestic abuse during lockdown, and many women may have been forced into ordering these pills by an abusive partner or family member. These women might then have to go through the abortion with only the abuser present. And in that situation, the woman would be unable to phone for medical help because the abuser would hear. There was actually a case of this reported in the Mail Online. And this poor lady said, the next day I felt really sick, faint and dizzy. I'm still bleeding even now a few weeks on. Because my partner is here and doesn't know what I did, I've not been able to ring anyone for any advice. And the next concern would be that women may take the abortion pills past the 10-week limit that I've mentioned. There have been reports of women in England taking the pills well past this limit, even past the normal legal 24-week limit. So I'll pass over to Kevin now, who's been doing some really interesting and useful work, a mystery client investigation, which gives answers to a lot of these questions.
Okay, well, thanks for that, Alethea. So my name is Kevin Duffy. I've been about 12 years now in the working in the delivery of healthcare services overseas. I did 4 years as a member of staff with Mary Stopes International, followed by another 2 years consulting to them or for them. So 6 years in total. And during that time, I had responsibility for strategy and the development of their global abortion clinics. In the last year and a half, I've been working with a number of pro-life organizations, including Christian Concern. And last year, about the middle of last year, Christian Concern commissioned me to design and then lead what we've referred to as a mystery shopper investigation into the pills by post, the DIY abortion at home. And I think just it would be helpful maybe just to start with a little bit of background, a little bit of introduction to that investigation, because we do use it a little bit as we go through the consultation now. So we had a team of volunteers, and essentially what they did was made calls to the abortion providers, so particularly BPAS and Mary Stopes, a couple of calls to NewPass as well. And they were posing as pregnant women seeking an abortion. The volunteers were acting a number of different roles to allow us to fully explore all aspects of safety and compliance. And there's a link to the investigation report on the website. The YouTube link will have it as well. And just as summary for now, in 26 cases out of 26, our team was able to obtain the abortion pills by post, even though they provided false information and they weren't even pregnant. So the investigation demonstrated a number of things, in particular that the abortion provider, they cannot be certain of the identity of the woman calling. They cannot correctly assess the woman's clinical eligibility for what they refer to as early medical abortion at home. We call it DIY abortion. They cannot be sure of how far on the woman is in her pregnancy, how many weeks she is, whether she is under the legal limit of the 10 weeks that Alethea mentioned. They can't be sure whether she is safe, whether she is alone, and whether she's not being coerced. And importantly, they're not even sure if it's this woman, the woman on the call, who will actually be the one taking the abortion pills. And I give you an example, three examples of the cases that we used. In one of the cases, the caller, the volunteer, posed as the mother of a pregnant daughter, a pregnant teenage daughter. And the mother made the calls, and she presented herself as being pregnant to obtain the abortion pills. And when she got those at home, she then used them to administer the DIY abortion to her daughter without social services being involved, and without the doctor, the daughter's GP being involved. So no safeguarding. In another case, apart from the mother safeguarding, but you know what I'm saying, okay? No official safeguarding. So in another case, our volunteer posed as a woman being coerced by her abusive partner into making the call and doing the abortion at home. One of the things Alethea mentioned a moment ago, we've seen a spike in potential domestic violence, intimate partner violence at home during lockdowns. And when making the call to the abortion provider, the abusive partner was sat beside the woman, prompting her to give the right answers. The abortion provider on the phone call was not able to discover this clear and present coercion. And telemedicine abortion requires 2, maybe 3 phone calls to the abortion provider. And usually the woman will be asked to give the first day of her last period in order to determine how many weeks pregnant she is. The legal limit, as we've said, is 10 weeks since the first day of her last period. In this case, the woman gave a date on the first call, and in the second call, she realized that date would have put her beyond the 10-week limit. So she changed her date and presented as being earlier in her pregnancy, just 7 weeks. And 4 times out of 4, that change of date, a very critical item of data, that change of date was accepted by the abortion provider, and they moved on and subsequently provided the abortion pills. And it's important to realize that it's not just our investigation, it's not just the investigation that was sponsored, commissioned by Christian Concern that has raised these concerns. There was an email sent by a senior chief midwife at the NHS to clinical directors and the heads of nursing in May of 2020. And that email highlighted a number of concerns related to the pills by post process. It mentioned specifically 13 related incidents, and this is just May, into May, so just a month or 2 into the whole abortion at home. It mentioned 3 police investigations, and one of those being a murder investigation, as there was concern that the baby had actually been born alive. And at the time of the leak, the NHS email, when that was being covered in the press, BPAS responded by saying that it was also investigating a further 8 cases internally in which it had provided the abortion pills beyond the 10-week limit. In October, the Department of Health and Social Care, Hancock's department, revealed that it had been notified by abortion providers that in the first 6 months of 2020 across England and Wales, 52 women had been prescribed abortion pills, even though their gestational age, even though their pregnancy was beyond the 10-week limit. And these are just known reported cases, officially reported cases. So it begs the question of how many others, how many more of these cases have been happening, how many more have occurred that we don't know about, that the regulators don't know about, and that the abortion providers know nothing about. So not just our concerns, but concerns raised by the NHS, senior management within the NHS, by the DHSC, the Department of Health and Social Care, and by BPAS, the largest abortion provider in Great Britain. And each of them agreeing that women are able to obtain the abortion pills by post when they are beyond the legal and the safe limit of 10 weeks. Okay. And it's because of those concerns that we're saying here in this question B, we should answer B, yes, it's had a negative impact. Okay, Alethea.
Thank you. Yes, so as you can tell from that, we already have abundant evidence that this policy has severe safety concerns. We're not just speculating here. We've had nearly a year of this now. So we have good evidence to put forward that it should not become a permanent measure. So on to the second question. Do you consider that the temporary measure has had an impact on the provision of abortion services for women and girls accessing these services, with particular regards to accessibility? So this is talking about, how easy it is to get there. That's one of the things the abortion lobby is putting forward. They say it's too hard to get an abortion, and this makes it easier. So for this one, it is okay to answer, I don't know, if you don't want to answer this question, because you could easily make the case that accessibility is not really the point. But Kevin has some suggestions for answering it has had a negative impact from his public health perspective.
Yeah, I think, Alethea, on this one, we could answer that it has had a negative impact. Telemedicine certainly can be cheaper and it can be quicker than in-person appointments. As it's talking about here, it can make the services, the healthcare services, easier to access. But the aim of medical care is not merely to adopt cheapest or quickest or most accessible approach. We always have to consider safety and well-being of those being served. And as I've already said, telemedicine, yes, it can play a part in the overall care pathway. It's a good way of making the appointments. It's a good way of getting in information to start with. Good way of providing some basic information. Afterwards, it's a good way of doing some good follow-up care. But telemedicine cannot replace the need for in-person clinical assessments, either of medical eligibility or in confirming the gestational age. And also, I think it's important that cost is mentioned a few times as being a barrier to women accessing care. And I know that in this question, some people are saying, look, telemedicine is more accessible for some women who have difficulties meeting the costs of getting to clinics, maybe taking time off work, or the cost of transport, or the cost of providing childcare at home, or whatever the other things might be. And I'm simply suggesting, look, where cost is a barrier to attending the clinic in person, it would be much better if the NHS made a way of providing that financial assistance so that those women can make the in-person visits to the clinic. Okay.
So question 3 is, do you consider that the temporary measure has had an impact on the provision of abortion services for women and girls accessing these services, with particular regard to privacy and confidentiality of access? And again, that's one of the abortion lobby's kind of big talking points, that it's so much more private. It's in the the privacy and comfort of your own home, rather than having to go into the clinic. So I think we've already mentioned some of these points. So privacy is going to be a concern if we don't know that the woman is alone at home. We don't know if anyone's going to be listening while she's having that call. That's particularly a concern in cases of domestic abuse. As well as somebody being in the room with her, there's the danger of technological abuse. Something like 3 in 4 women who are victims of domestic abuse reports having their technology monitored, their phone monitored. So it is a particular concern that they may not have privacy. And I think you mentioned that as part of your mystery client exercise there.
Yeah, this is an important one, Alethea. And the abortion providers make a big thing of their safeguarding measures and the care and attention that they take to make sure that that women are safe. And I've listened to about 90 of these phone calls now, and the abortion provider most always, usually asks the woman if she's alone and in a private place. and we'll ask a few times to confirm that the woman feels safe, and that she's able to have this discussion in private, inquires about aspects related to intimate partner violence or coercion. And some of the questions are actually quite involved. They get into a lot of detail and specifics. But regardless of how well the questions might be worded or the good intentions behind them, the abortion provider is simply not able to discover if the woman is actually alone and safe and not being coerced. And we had a number of our calls in which the volunteer had her abusive partner sat beside her acting the role. And during those calls, she was asked, just as all of the women are asked, are you alone and do you feel safe? And she said, yes, I'm alone and I feel safe, whilst her partner was sat beside her. And her partner during the call can be seen coercing, prompting her to make the right answers at the right time. And during those calls, the abortion provider just simply was not able to discover that somebody was sat beside the woman. It's not possible.
Yes, and the abortion lobby have been claiming that they can fully kind of do these safety checks over the phone. But as you know, you've proved it just isn't possible. No. And obviously the flip side of privacy is that means the woman is alone, and that's not generally what you want with a medical procedure. You normally want medical supervision. So I think we do have to kind of see through these kind of nice sounding terms as to what they actually mean. So the next question, question 4. Do you consider that the temporary measure has had an impact on the provision of abortion services for those providing the services? This might include greater workforce flexibility, efficiency of service delivery, value for money, etc. So again, this one that it would be okay to answer, I don't know. It does seem to be aimed at kind of people for the who work in the NHS or in abortion services. And if any of you do work in those areas, your answers will be particularly valuable. So please put any information that you have, any feelings that you have on the matter. But if you did want to answer that it has had a negative impact, again, Kevin has some suggestions.
Yeah, I think the main one here is actually, I just want to pick up on the last clause in that question, the value for money aspect, and tackle that, because again, I'm seeing some of the abortion providers are now saying telemedicine's a wonderful thing. Look at the money that it's saving. It saves the clients money, the women themselves, in transport, etc. But it also saves the NHS money because our costs are much lower. Now, interestingly, we haven't seen a drop yet in any of the fees being paid, and it'll be some time before that gets reflected. But what I want to say is, look, value for money in this case, the overall cost of abortions, all of them across England and Wales for the NHS, it's a very, very small part of the overall NHS budget. And though those costs might be reduced a little bit by the implementation of telemedicine abortions, we should never allow cost considerations to weigh more heavily than ensuring each woman is correctly and professionally assessed and is presented with the opportunity to discuss any of her concerns in person with a trained counsellor before giving her consent to the abortion. So I'm not a fan of telemedicine abortion being used, and I don't like the idea of it being argued here on a value for money basis. I think we need to pay more attention to the care and the well-being of the women involved. Okay.
Yeah, in fact, I do find this question quite sinister in a way, because they always talk about caring about women and providing the best care for women, and now this consultation question from the government is talking about saving money, which should not really be the consideration here. So the next question is similar about NHS services, and it's, have other NHS services been affected by the temporary measure? So when I first wrote the briefing on answering this, I just put, I don't know, because to be honest, at that point, I didn't know. But actually, Kevin and others have been doing some really interesting work on how it is affecting other NHS services through freedom of information requests.
Yes. So on the calls, abortion providers, when they are talking to the women, will talk to them about what happens when they take the abortion pills, and they will talk to them about complications that might arise. So there are side effects and there are complications. And for the complications, they say, look, here are the signs of complications that might happen. So these will be things in particular around bleeding. So not bleeding enough, bleeding too much, heavy bleeding, and signs of being incomplete. So what they refer to as an incomplete abortion. And that's when the abortion pills have not worked correctly, which result in parts of the baby, parts of the placenta remaining behind in the womb. And they describe the signs to look out for this. And if any of these signs, if they notice any of this, if they're bleeding too much, or if they don't think it's worked completely, they are told, go straight to the nearest hospital. Go to the nearest accident and emergency for essential treatment. They're told, don't delay, don't take any time, don't phone us, go straight to the hospital. And it's interesting that when women do that, let's step back. It's not the abortion providers that are managing these things. So once the pills are posted out, it's the woman herself. She's on her own. She's taking the tablets, the abortion pills by herself. Okay. She's monitoring the effect of the tablets herself. She's the one assessing whether or not the abortion has proceeded correctly, or whether there are danger signs for her in terms of bleeding or being incomplete. Incomplete will lead to ongoing bleeding, maybe even infection. So these are things that she can't delay on, but it's left to her to decide. And the instructions from the abortion provider is go straight to the hospitals. So we've followed through on this, and we've written out to a number of ambulance services and to NHS Trust hospitals. So we've made freedom of information requests, and we're getting those responses back now. We've had a number of them already, and a growing number of responses building up. And what that shows is that women are presenting. Both they're phoning 999, they're getting the ambulance service, and they're presenting at hospitals with incomplete abortions. And in many cases, they need to have a medical intervention in order to fully remove the remains of the pregnancy, and to deal with any bleeding and to deal with any potential infections. And my analysis of those responses so far show me that the incidence of these complications has not changed. It's the same now with abortion at home and DIY abortion, or pills by post, whatever you want to call it. It's the same as it's always been. Okay, there are women that are going to hospital. That hasn't changed, even though we're being told by BPAS, by Mary Stopes, by the Royal College of Obstetrician and Gynecology, the RCOG, that actually it's much safer. They're saying that abortion pills at home, do-it-yourself abortion, is much safer than it ever was even in the clinic. That's completely ridiculous. Okay, and now we're getting data to support this. So we will come out in the next week or two with a fuller report on those findings. But just bear in mind now that it's left to the woman. It's, she has to look after herself, and when things go wrong, she ends up in the hospital, not back with the abortion provider. Okay.
Yeah, so it's just really important to note that in a way, the abortion clinics are now shifting that responsibility onto the woman mostly, and then onto these other NHS services, which I think we could agree have got enough to be doing at the moment.
Indeed. Indeed.
So the next question is a free text one. There's nothing to select. What information do you consider should be given to women around the risks of accessing pills under the temporary measure if their pregnancy may potentially be over 10 weeks gestation? So that's actually a really interesting question, because it seems to me to be admitting the fact that women are taking these pills over 10 weeks, which is against the law and against medical advice. Also a bit cynical to be asking the public as to what we should be telling women about this. probably something later to work out. But it's a good opportunity for us to answer this. So obviously here we're talking about the risks of taking these pills over 10 weeks. That's not to say that, you know, having abortions under 10 weeks is any morally different. But again, for this consultation, we're talking about this particular measure. So there are a number of risks to taking the pills over 10 weeks. They are designed to be taken up to about 10 weeks of pregnancy, and they're less effective and more harmful for the woman when taken later in gestation. So, for instance, in one UK study, more than 50% of women having medical abortions after 13 weeks needed subsequent surgical intervention. So obviously, if you need to go and have surgery, that's both traumatic and negates any so-called benefit of having an abortion at home. So the abortion complication rate increases rapidly with each week of gestation, with one study finding a 38% increase in each week. And all these stats are in the SPUC briefing if you don't manage to get them down. Recent research shows that 16.3% of women who had medical abortions at 57 to 63 days and 20.5% of those who had medical abortions at 64 to 76 days made an unscheduled return visit because of concerns about complications. Another concern we could raise here is the issue of pain for the unborn baby. So some researchers believe that pain sensation may occur before the 10th week of gestation and possibly as early as 6 to 7 weeks due to the maturation of particular neural structures, as well as the lack of pain inhibition mechanisms. And there's also the fact that by 10 weeks, the unborn baby is 1.5 inches long and clearly recognizable, which may cause more distress for women passing the baby alone at home. So I don't want to get too graphic, but I think people sometimes think, taking an abortion pill is just like poof, and and pregnancy gone, baby gone. That's not the case. The woman has to pass the pregnancy, and obviously the further along the pregnancy is, the more pregnancy remains there are, the more visible the baby, the fetus is going to be, and this can be very traumatic for the woman and something that she should be aware of if she's going to be taking pills later than is advised. And actually, abortion providers themselves point out the risks of taking these pills later in gestation, which I think Kevin's going to talk about.
Yeah, so thanks for that. So Priscilla, if we can have the BPAS, yeah, thank you. Okay, so on the screen now, this is on the BPAS website. Well, yeah, okay, so about in the middle of that table, it shows the blue column, first of all, is up to 9 weeks. So that's 8 weeks, 6 days and below. And in the middle, it shows you that needing surgical treatment to complete abortion, 3 in 100. So that's saying that 3 women out of every 100 women, so 3%, up to 9 weeks, will actually need surgical treatment in a hospital to complete the abortion. Now look at the column beside that, to the right-hand side of that. This is just in the next week, just 1 week, the 9th week. So we're still within the legal 10-week limit. Okay, this is not going beyond that, but look at the jump already. It goes to 7 in 100 just in that 1 week. And that underscores, this is BPAS underscoring what Alethea has just said to you, that the abortion pills, the efficacy, how they work, decreases, it diminishes as the pregnancy develops, as it gets older. And I think this question, you can go back now, thanks, Priscilla. I think this question is just really cynical, okay, right? I think what it demonstrates is the reality that's known to the government and to the DHSC, that gestational age, it's the critical determinant of the safety and efficacy of medical abortion. And that the fact is that some women will not provide the correct information to enable the abortion provider on the telephone to accurately assess that gestational age. They'll either get it wrong just by mistake or they'll get it wrong intentionally. Okay, we know that even in the RCOG, the Royal College's guidelines, it says there that it's simply not possible to be absolutely certain of the gestation by telemedicine, and that some women will be beyond the 10 weeks, and we just need to take that into account. So they say that's going to happen, just deal with it. Okay. And I'm saying, well, you can't tell by telemedicine, and the impact on women increases beyond those 10-week limits and as she gets older. And particularly, it may be that she gave the right information. We've had a few calls now in our mystery client investigation where it's quite clear that if the woman just delays even a week or two, 7 or 10 days after receiving the pills in her home, she'll be beyond the limit. Okay. So she might delay because it's just not convenient on the day she receives the pills. She may be waiting to the weekend. She may be waiting until the kids have gone somewhere else. Lots of different reasons. She may be waiting until her partner's not in the house. So, this is an important aspect. And asking this question, I think, just reveals that the government sees this as this is a problem, and it's quite a cynical approach. Women deserve better than this. We need to afford them the protection, and that can't be done by telemedicine. I think more than anything else in this whole consultation, this is the one question for me. Telemedicine cannot protect against this being over the 10-week gestation. That can only be fixed through an in-clinic, in-person consultation. Okay.
Definitely. Well, let's hope that this cynical question means that the government is recognising some of these concerns, some of these realities, and will act accordingly. So coming up to question 7, outside of the pandemic, do you consider that there are benefits or disadvantages in relation to safeguarding and women's safety in requiring them to make at least one visit to a service to be assessed by a clinician? So this is almost encapsulating what this whole thing is about. And obviously a lot of what we've said already applies to this. So obviously for this, we have to say, yes, benefits, but what we're really saying is kind of the risks of the telemedicine approach, not kind of saying that we like the clinic approach particularly, but again, for the purposes of this consultation. So just to run through the benefits of going to a clinic as opposed to having the pills by post. So one of the dangers of having the pills in the post is not adhering to the precise time intervals between the 2 stages of the abortion. So women take 2 drugs, mifepristone, which cuts off nutrients to the baby, and then misoprostol, which induces bleeding akin to a miscarriage. But how you take these pills, the time interval is important. So taking the second dose incorrectly increases complications for the woman, and she may require surgery. So you're supposed to leave it a certain amount of time, but obviously, understandably, a lot of women might want to get this over with more quickly and might take it sooner than is expected, and that can cause complications. Another concern is missing an ectopic pregnancy, so when the baby develops in the fallopian tubes, and that would normally be picked up by an ultrasound scan. But of course, if you're not having a scan or any kind of physical consultation, that can be missed. And in that case, you might need emergency surgery. It can be life-threatening, and you definitely should not be taking abortion pills. There's also the emotional distress. Many studies show that women experience emotional distress after an abortion, and other studies show mental health problems for women. So I'm just repeating myself there. Home abortions may lead to more adverse psychological consequences, in part because the woman may be alone when she aborts, and she also may see the baby who's expelled, as we've said. And other risks that should be considered. The problems of regulation. I think we've kind of shown in some depth now how you just can't regulate, that the time limit is being adhered to, or any of the other safeguards. And in England, police have investigated the deaths of a newborn baby and a baby at 28 weeks gestation after their mothers took abortion pills well past the legal limit. So there have just been huge, massive violations of this. And as Kevin spelt out, the mystery shopper exercise showed that abortion providers are sending women who don't even exist these pills. So their checking process clearly leaves a lot to be desired. We've mentioned domestic abuse a lot, which is strongly associated with abortion. Intimate partner violence is a risk factor for abortion all over the world. And removing the provision of abortion pills from a medical setting increases the opportunity for abusive partners to force women into having abortions. And it also misses the opportunity to detect domestic abuse. So, in fact, studies on domestic abuse have suggested there should be greater efforts to ask women if they're subject to domestic abuse when they present for an abortion. And not having a private conversation with a doctor in the clinic removes that opportunity.
Yep. So
yes, Kevin, what else do you think?
Well, I think let me just summarize on this by saying, look, for me, from looking at this, there are clear benefits to requiring at least one in-clinic assessment by the abortion provider. In-clinic consultations and their assessments will overcome the safety and safeguarding gaps which are clearly existing in remote services by telemedicine alone. And I've got 4 or 5 things just in summary. So clinicians will be better able to verify the identity of the woman with an in-clinic visit. They will be able to accurately assess the gestational age of the pregnancy, one of the most critical aspects. They can assess the clinical eligibility of the woman for medical abortion treatment. They can be sure that the woman has an opportunity in private to disclose and discuss any issues related to abuse or coercion or other concerns related to her desire for the abortion. And they can have certainty that it is this woman, the woman present in the clinic with them, that will be the one using the prescribed abortion pills. So there are clear advantages over telemedicine. The gaps in telemedicine can only really be overcome, not by improving telemedicine, but by ending telemedicine immediately and going back to an in-clinic assessment. Okay.
Thank you. So the next 2 questions are what we call equalities questions. So looking at how this measure would impact different communities of people, particularly under the categories of people under the Equalities Act. So question 8 is, to what extent do you consider making permanent home use of both pills could have a differential impact on groups of people or communities? So we picked out a few of the protected characteristics that might apply here. So one is obviously pregnancy. Pregnancy is a protected characteristic. As we said, DIY abortions can increase abuse of pregnant women. Pregnancy can be a trigger for domestic abuse, and existing abuse may get worse during pregnancy or after giving birth. And abusers who know that women can get abortion pills through the post will be able to cover up their abuse more easily. Pregnant women who are abused are at greater risk from abortion. In a study of London clinics, there was a 6 times higher rate of intimate partner violence in women undergoing abortion compared with women receiving antenatal care. So women seeking abortion are in a higher risk category for domestic abuse, and victims of abuse are at risk of being forced into abortion. And as we've said, home abortion removes both the opportunity for detecting abuse via a private consultation and makes it easier for abusers to force a woman into abortion. Another potential category of people who could be affected is religion or belief. There could be the conscientious subjection rights of healthcare workers might be compromised, just in that people who might not ordinarily be involved in abortion provision might end up being, for instance, having to post these pills to women. Do you have anything to add on this one, Kevin?
Not on this one, no.
Great.
Okay.
Yes, just getting conscious of time. So question 9 is another equalities one. To what extent do you consider that making permanent home use of both pills for early medical abortion would increase or reduce the difference in access to abortion for women from more deprived backgrounds or between geographical areas with different levels of disadvantage? So some points you could make here is that poverty can drive women towards abortion. Statistics from the Department of Health and Social Care reveal that women living in more deprived areas are more likely to have abortions than women living in less deprived areas. The rate in the most deprived decile is 26.1 per 1,000 women, which is more than double the rate in the least deprived decile of 12 per 1,000 women. And we just want to spell out that abortion is not a solution for poverty. There's a risk that abortion pills by post will be promoted as being especially important for women in deprived areas. And the ease and speed of getting abortion pills will mean that women who are considering abortion for financial reasons have less time to make their decisions. I mean, this process can be really very quick. You just phone up, get approved. You could have the pills in the post next day, 2 days later. So critically, DIY abortion could mean that women do not get the help they need to deal with their circumstances. And I think you found it was very quick in your mystery client investigation.
Yeah, I mean, in some cases, 2 or 3 days. I mean, from the first call to receiving the pills. I would just add, there's one thing to add to this. I think that, I think we're both agreeing, Alethea, look, that safe provision can only really take place with in-person clinical consultations. And we would propose that where necessary, if a woman has financial difficulties in getting herself to the clinic, that the government, the NHS, provides funding to cover those out-of-pocket costs. And I think it's worth noting that, regardless of where we stand on abortion, worth noting that, look, they've done that for women in Northern Ireland who at a time needed to travel to England or Wales for abortion services, where they were meeting all of those costs. So here again, telemedicine's not the answer. They need to have in-person consultations in a clinic. And if cost is a barrier, then the government should remove that cost as the barrier, not provide telemedicine. Okay.
So the last question here is probably the most important. Should the temporary measure enabling home use of both pills for early medical abortion, and then you select one below, become a permanent feature, end immediately, be extended for 2 years, several other options. And obviously what we're suggesting you put here is end immediately. This is such an important question. Basically, even if you answer nothing else, just go through and answer this question, though please do answer the other ones. We spelt out that this measure has huge safety concerns. We've not really mentioned it, but it is a fact that it was not debated in Parliament. It was just done by diktat. It's not been properly considered. And pandemic or no pandemic, women deserve better than this. We shouldn't be letting this go on for 1 minute longer. It should end immediately.
Yeah, and I think that, look, let's have no hesitation on this, end immediately. Abortion clinics are open. They're open today. In this lockdown, they are open for business. Okay, so there's no need for telemedicine, do-it-yourself abortion. So just end immediately. Nothing else to say, sorry.
And immediately. So once you've answered that, there's just another box for any other comments you might want to make. So perhaps if you found you've not managed to fit some of the other points we've mentioned in, or you have any of your own points, this is a really good place to put them in. A few other points that we suggested is that taking pills at home is being promoted as being safe and simple, but it's fraught with risks and complications as well as being traumatic. And actually what's not being mentioned here is the promotion of medical abortion over surgical abortion. Complication rates for medical abortion are actually 4 times higher than after surgical abortions, 20% compared to 5%. Many of the risks, obviously there are risks to women from medical abortions and abortions generally, even in a clinic, and the government should be taking account of that. And ideally, the government should be undertaking a public information campaign to inform all women of the risks they run in having an abortion, rather than making it easier and less safe. Okay, I think that's about what we want. Or sorry, Kevin, did you want to say a bit more before we go to questions?
No, I think what we're saying is, look, let's not forget that we were told that this was going to be a temporary emergency measure because of the risk of COVID infection, and it is, they didn't debate it in Parliament, as we know. Hancock just made the decision. That's been challenged in the courts by Christian Concern. This is just a cynical approach to now having, something that was meant to be just temporary, cynically now to be taking this consultation and moving, with an aim to making it permanent. And the abortion providers are assuming that that's what's going to happen. They're assuming that this will be made permanent. So let's, take action, fill in the consultation, complete the forms, and say end immediately. It's important that we do that, even though we have our views on whether abortion should happen or not. We need to say end immediately in this case.
Definitely. So we've got a bit of time now for questions. If you haven't asked a question yet and you would like to, just put it into the comments, and Ben is going to moderate them for us and ask us some questions.
Hi, all, and hi Alithia and Kevin, really great, really helpful for that. Hi all, I'm Ben John with Christian Concern, and we've been campaigning particularly on this issue. We've been doing a judicial review challenging the government's decision to allow the DIY home abortions when very undemocratically Matt Hancock and the Department of Health and Social Care welcomed in this this new policy, and actually did a double U-turn back in March at the start of lockdown. And we've mentioned earlier that this has been something that the pro-abortion lobby have been wanting for a long time. So it's hugely important that we engage and speak on this. So some questions that we've had in. Paul Gardner wrote in earlier, maybe this is for you, Kevin, maybe you could speak about some of the research that you're doing into this. Do we know the extent of the A&E attendances and number of people, women who've been referred to, or not referred, had to go to A&E as a result of DIY home abortions?
Yeah, as I mentioned, we've got FOI responses coming through. We're compiling those data and doing our analysis. We'll do a fuller report in the next few weeks. I think fair to say now that the numbers of women attending hospital isn't in decline, and the numbers we're seeing are well reflected in that BPAS table that we put up. So we're finding, 2, maybe 3 women in 100 attending hospital for incomplete abortion, where they need an intervention, where they need a medical intervention. But we've got other data about the numbers of women making phone calls to the ambulance service after taking the pills and so on. So yes, we've got data, and it will be published in the next few weeks.
Great, that's hugely helpful. So a question, so theoretically, someone could just order these pills over and over and over again, and I guess presumably, for any reason, is that possible?
Yeah, it's more than possible. So we reported 26 cases in our investigation. I don't have 26 volunteers. Okay, so many of my volunteers were making multiple calls. Many of my volunteers were actually making multiple calls from the same address to different providers as the same person to different providers. So, within a week, they were receiving packs from all 3 providers, from BPAS, from Mary Stubbs, from NewPass. So it's definitely possible. There's no checking, and there's no cross-checking. There's no validation of the person, no verification.
Yeah. And the abortion provider doesn't have to inform the woman's GP. I think they do ask if the woman wants that to happen, but if they don't, then it doesn't. So there's, as you say, there's no cross-referencing with any other kind of health checks.
And they also don't take the NHS number. So within the official records, there's no linking back to NHS numbers on this either, which is a gap. It's a major issue that needs to be addressed at some point.
Yeah.
And if you wonder why so much of our research comes from Sweden and other such places, is because they have much better data than we do, precisely because they do take this information and they don't in this country.
You're talking about the longitudinal data now, Alithia, so that there's no way of tracking back when women present later in life with other health issues. There's no way of tracking that back to prior abortions with the data. There's just no links.
Yeah. Paul Moran, in the context, would it be possible that a mother could give a daughter the pills? I guess maybe this could be generalized to coercion. I guess the nature of the pills, can it be used secretly, coercively, in these kinds of things? Could an abusive partner slip them to his wife or girlfriend? Would that be possible? Kevin, would you?
Yeah, well, I mean, I think it's possible. The tablets, I suppose, could be mixed up into food or whatever. That's not typically the stories we would see. The stories we would see would be more of a coercive nature, where it's not where the abuser is doing it to the person and the person is aware that it's happening, and they're being abused into it or coerced into it. And certainly, I have no doubt that many mothers will have obtained the pills for their adolescent pregnant daughters, and that those daughters will not have been receiving care from, whether it be school nurses, their GP, social services or anybody else. They would have been completely outside of the system.
Yeah. Maybe a question to you, Alethea.
That's happened even before this measure. There has been several cases of, exactly, putting in food. But as you say, that's been about 4 or 5 cases in the last 50 years that I'm aware of.
Yeah.
But obviously, a situation where it's much easier to get hold of those pills isn't going to make that better.
Yeah, certainly. Alethea, maybe a more kind of question about the consultation at all, which I'm sure maybe some have in mind. Presumably, it's assumed that many respond to the consultation. To what extent is the government bound by the results of this consultation? Or to what extent do they have to follow the results?
Well, the answer is that they're not really bound to it. They don't have to follow the results. But it obviously looks a lot better if we get lots of responses to the consultation. And the stronger our response is, the more the government is going to take notice of it. And we will obviously be backing this up with other campaigning. But once this has happened, we'll be asking people to write to their MPs. And actually, I think we did find that a lot of MPs were uncomfortable with this. Even if they approved of it for the pandemic, nearly every MP that I heard back from said, this is temporary. I'm assured that it will go back to normal once the coronavirus legislation is over. So I think we do have a good chance here. While the government doesn't have to listen to a consultation, I think the fact that they are consulting, they've put an option to end immediately, there are some positive signs, and the more responses we get, the better our chances.
Yeah, absolutely. Pius X3 has put, how are abortion providers benefiting from DIY home abortions compared with in-clinic abortions? Kevin, would you know if there is a benefit or why this is such a big issue for them?
The abortion providers have a long-term strategic aim towards what I call self-managed medical abortion. So this is something they've been pushing for an awful long time. Their ideal is to, in GB, is to decriminalize abortion and eventually to have the abortion pills available, perhaps even over the counter at a pharmacist. That's their long-term aim. And Mary Stopes is pushing very strongly on that self-managed medical abortion strategy overseas. More than 80% of the abortions that they provide now globally are pills sold across the pharmacy counter. So we can see, this is where they're headed. This is what they want. And they want it for 2 or 3 reasons. They want from their point of view, they're saying this makes it easier for women. It's more accessible. It's a woman's choice. It's her own private decision. Why is the law, being used to sort of prevent this or make it more difficult? Why do we need doctors involved? All of these sorts of questions.
Yeah, okay. And just a quick follow-up question on that. The abortion pills are being provided on the NHS, aren't they?
Yes, they are. They're not, so there's no, are you talking about cost to the woman or what?
Yes, cost to the woman.
Yeah, these are free of charge, free of cost to the woman.
Okay, that's really great, really helpful. Thank you, Alethea. Thank you, Kevin, for the questions and for the presentation this evening. And for everyone who's tuning in, it's really helpful to know that the slides will be available online, and this video, this whole session is going to be staying online. So please do forward and share the video and the slides to people in your communities, families, friends, churches, whoever, so that we can mobilize as many people as possible to respond to this consultation. So please do forward it and share. I'm going to hand over now to Linda Rose from Voice for Justice, who's going to close and round off this briefing for you all. Thank you.
Thank you, Ben. And can I say to you a very big thank you to Alethea and Kevin for guiding us so expertly and competently through the consultation. But thank you too to all of you who've joined us tonight. We hope that you found the briefing helpful, and thank you for your willingness to make your voice heard. My name's Linda Rose, and I am CEO of Voice for Justice UK. We're basically a campaigning group working to defend human rights and freedom. And as a part of that, along with the other groups who joined together to put together this briefing, we work to defend the right to life of the unborn and to be a voice for those who can't speak for themselves. And we're very pleased to be a part of this pro-life coalition. Historically, it's always been said that the safest place to be on earth is the womb. But sadly, that's no longer true. The womb today has become very dangerous, and whether or not a baby survives has become something of a lottery, dependent on whether or not it's wanted. Recent data released by the ONS showed that a baby had a 1 in 4 chance of winning that lottery. But DIY abortion has narrowed those odds. And since these so-called emergency measures were introduced last March, we've seen a huge leap in numbers from around 100,000 abortions between January to June in 2019 to 105,000 abortions in the same period last year, and the numbers are going up. There is absolutely no doubt that this rise is attributable to the easy access to DIY abortion, which has really put the killing of the unborn on a level with having a tooth removed or going along to the pharmacy and asking to buy Imodium. Because more and more the unborn are being regarded as disposable. And these measures actually trivialize what should be sacrosanct, the care of a new life. But as you've heard tonight, the major concern with DIY abortion is that it endangers women's lives and it's open to abuse. As we've heard, abortion providers say that medical abortion up to 10 weeks is completely safe with hardly any problems. How wonderful. In fact, that's simply not true. In fact, I'd go a lot farther and say it's an outright lie. There can, again, as we've heard, be all sorts of complications following on abortion. And without proper care, women will not just require treatment, but they can die. As you've heard from the Mystery Client Survey, women aren't being properly assessed. And it's all too easy, whether intentionally or completely by accident, to give wrong or misleading information. And it's all too easy, too, for a woman to sit on the medication for a few days or even a few weeks while she thinks about it. Does she really want to go through this? Or she can even give it to someone else. So women are hugely at risk. At Voice for Justice, we believe that every life is precious, which means that both the mother and the unborn child matter. And we also believe that every individual conceived has a God-given destiny, which actually goes a long way beyond just a short time spent in the womb. Long term, the real victims of what's starting to look like genocide are actually you and I. Humanity as a whole. Because gradually we're extinguishing the human race and we're being systemically dehumanized. We're not caring for each other properly anymore. And in the process, who knows what gifts are being taken from us? Gifts that the world needs urgently if we're going to survive and to look after each other properly. That you're here joining with us tonight says that you too believe that those lost lives are precious and that women deserve so much more than this cavalier treatment that diminishes and dehumanizes the entire human race. So it's vital that we do say to legislators, this is wrong. It's got to end. No more. For the protection of the mother and for the right to life of the unborn child, and for the sake of society as a whole. It is absolutely vital that proper medical assessment remains in place and that proper safeguards are maintained. So thank you again for standing with us and for your willingness to make your voice heard. If you do need any further help answering these questions, I don't know, maybe you've already finished the briefing during this time together now, but if you do need any further help, all the organisations involved have got briefings put up on their websites, or will have in the next few days. And all I know will be more than happy to answer any questions you might have. And please encourage your family and friends to fill in the consultation too. And of course, we encourage you to share this video as widely as possible, which we hope will be of help. Numbers matter. And it's vital that as many people as possible do respond, making the point that DIY abortions are not just harmful to women, but they're harmful to the whole of society. The reality is that actually we simply can't afford that cost. The consultation ends at midnight on Thursday, the 26th of February. So please respond as soon as you can. And thank you again for joining with us tonight.